Hello, everyone, and welcome to the AMCI E&M series. We've designed this series to break down the E&M guidelines into manageable, digestible nuggets to ensure that you have the best possible learning experience. We encourage you to watch the playbacks as many times as you need until you fully grasp those guidelines. And if you're seeking CEUs, simply click the link in the description to enroll in our online course. All right, that was kind of rude. If you didn't know, I'm Mrs. J, the Curriculum Director at AMCI, and I am absolutely thrilled to be here with you today. Now, let's go ahead and let's take a moment to introduce our fantastic team. And we're going to start with Miss Tamika. She is our Assistant Curriculum Director and Resident QHP. Yes, she is a physician's assistant. Now let's turn our attention to Mr. Sandeep, who is also a lead instructor at AMCI, and he is our resident pharmacist with a master's in pharmacy. And introducing our dedicated AMCI approved interns, Miss Dolly, who holds both CPCA and CCS certifications. And last but not least, Miss Jasmeet, who has an MS and a medical background as a CNA. And with such an incredible team by our side, we are excited to dive into these E&M guidelines together. So without further ado, let's get started on this journey. And this is a 4-part E&M series. Yes, we will discuss in part 1 the AMCI annotation technique called CHUN. We're going to teach you how to CHUN your E&M section. We're also going to learn to code office visits and scoring the medical decision making in part 1. In part 2, we're going to discuss inpatient coding, hospital observation. We're also going to talk about consultations and emergency departments. Part 3, we're going to talk about nursing facility visits, prolonged services. And part 4, this is where we're going to summarize all of it and we're going to test your knowledge. But rest assured, throughout the parts, we will be testing your knowledge. And finally, keep in mind that we will consider the 2023 guidelines and apply them every step of the way. Now, let's get this started.
Thank you, Ms. J. So, coders, how are you all doing? Yes, as Ms. J said, we are into the final week of March Madness, and now it's time to give the copyrights. CPT copyright 2023 American Medical Associations all right reserved. CPC is a registered trademark of AAPC. The AAPC content found within this presentation is a copyright of AAPC. The credentials CPC, CRC, COC, CPMA, CPB, CP, PM, CPCO are owned by AAPC. AMCI does not own the rights to these credentials. The credentials CCA, CCS, CCSP, RHIT, RHIA are owned by AHIMA. AMCI do not own the rights to these credentials. The keyword concept FDR, CHUN, AMCI FAB 7, AMCI ICD-10, Flip Tab, and MCG are the trademarks of AMCI. So where are we now? We are in the week 4 and we will be testing the knowledge with application to the practice scenarios and reviews. Yes, we are going to have a lot of practice scenarios in this week 4, and the goals of the presentation for today is the scenario review. Yes, we revisit the same day and admit. We'll be reviewing them. We will be reviewing the ED visits, the emergency department visits, and the prolonged services. And there will be also review on the 2023 changes and the AMA guideline changes. And yes, now it's time to talk about AMA errata. So erratum is a Latin word for the correction to the publications, and you have been asking for about this here about the AMA erratum. So this mostly it's about the language changes and any other changes which has been made. You can see as in the slide, there's been changes like for the independent interpretation. That's a test that is ordered and independently interpreted may count both as the test ordered and interpreted for the appropriate source for the purpose of the documents reviewed. Documents from an appropriate source may be counted. So all these changes on the AMA errata is available in your LMS. So you can go ahead and check the LMS for them. And again, you have changes that is pertaining to evaluation and management office or other outpatient services, evaluation and management nursing facility changes as well. So don't forget to go and check your LMS for the AMA errata and AMCI homework errata. So you can also find the changes by looking into the term difficulty. That's where we will be having erratum in AMCI homework. And a big shout out to the MH. I won't specify the names. I won't take out the name. So it's one of you. Thank you, MH, for pointing out a change here. So medical decision making, it's all about the compliance, guidelines, and regulation. And we will be doing a few exercises on medical decision making on the week 4. So are you ready, coders, to test your knowledge? Yes, I know you all are ready and excited here. So let's get started. Before that, I want to have a quick look into the keywords to the highlight for the E&M documentation, age of the patient, the diagnosis, signs and symptoms, exams, the procedures, anything the doctor does, the total time, medical decision making, data reviewed. So all these are going to be highlighted in E&M documentation for solving the scenarios. So how to solve the E&M medical coding? Answer question sections. Yes, we have few questions and we answer them for all the E&M medical coding scenarios, whether there is a medically appropriate history or exam performed, the location of the visit, yes, where was the visit happen, and the type of the visit, whether it's a new patient, initial, established, subsequent visits, the total time of the visit. If there is no total time documented, what we do is we go ahead with the medical decision making. We'll be inventorying them and scoring the medical decision making by using the PDR chart and E&M tables to select the code, and finally applying all the guidelines. So that's all. And this is your first scenarios, and we'll be doing a little bit change from previous. We will be cutting short the time, and you will be getting around 60 seconds to answer these questions. Yes, this is a challenge we put forward for you, and I am sure you are ready for this challenge. So to read out the first scenario, I would like to invite Ms. Jasmeet on the floor. Ms. Jasmeet, you can take it away.
Thank you so much, Mr. Sandeep. Okay, let's start with the first scenario of this webinar. Okay, score the MDM and provide the code that describes the level of service for the encounter. Your options are 99282, B 99283, C 99284, and D 99285. Subjective. A 32-year-old female who presents to the emergency department with chief complaint of increased post-operative swelling. This patient had right neck lymph node biopsy done 3 days ago. Patient has a dressing in place ever since then. For the past 24 hours, she feels like she has increased swelling and she presents now because of it. She denies any accompanying fever, chills, or sweat. The ED physician carried out a detailed exam where he found soft tissue swelling, which extends about 3 centimeters from the wound itself. However, no warmth or erythema. Assessment. Post-operative swelling plan. I have discussed the case with the ENT surgeon. We have redressed the area. Patient is reassured and will be following up with her doctor tomorrow for drain removal. Score the MDM and provide the code that describes the level of service for the encounter. And coders, you can use your PDR chart for this, and I believe you have a minute to solve this scenario. Thank you.
Okay, coders, that's 1 minute. And how are you all doing? How are you all doing with this challenge? Let me have a look into the chat. Yes, I can see lots of answer in. I can see a lot of correct answers in, and I'm delighted. Yes, awesome. So you guys are up for this challenge, and let's solve the scenario. Let's highlight the keywords. Um, okay, there's a 32-year-old female who presents to the emergency department, and a patient comes with a complaint of postoperative swelling. There was a biopsy done 3 days ago, and the doctor discussed the case with the ENT surgeon. And what they have done is they have redressed the area, and that's all we are having. Now it's time to ask the questions. Was there a medical appropriate history or exam performed? Answer is yes, there was medical appropriate history and exam performed. And how about the location of the visit? This is an emergency department visit, isn't it? And the type of the visit, whether it's a new patient or established patient, that's not important because it's an emergency department. And the total time of the visit is also not going to play a big role here. So what we are going to do next is we are going to inventory and score the MDM table. So for that we will be using our PDR chart, and in the diagnosis we are having post-operative swelling, and procedure what the provider did or going to do. There's a discussion of this case with the ENT surgeon, right? You have seen that, the highlighted keywords, and they have done a redressing of the area. So that's all doctor has done. And now I will be looking for the problem in the PDR table, the problem column, the PDR table. So I find it falling under acute uncomplicated illness or injury, right? For the diagnosis, so it's a postoperative swelling. So that's where it fits into. And now let's look into the data. So data, there was a discussion of the case with the ENT surgeon. So that will fall under the category 3, the discussion of the management or the test interpretation with an external MD, qualified healthcare professional or appropriate source. So that's a moderate level data for me. And for the risk, mm, the doctor has pre-addressed the area, so there's a minimal risk, so that will be a straightforward risk for me. And next what we do is we'll be removing the lowest level, and we'll be taking the next level. So that is going to be a low risk MDM. And the code, the CPT evaluation and management code for this encounter is going to be 99283 option B, as most of you have said. So great work on this, coders. So thank you, Ms. Jasmeet, for reading. And now we are going for a scenario 2. So it's repeats. It's just 60 seconds. You have got to solve this one, and I'm sure you're going to do great for this one as well. So, Ms. Jasmeet, thank you, please.
All right. Thank you so much, Mr. Sandeep. All right, coders. So score the MDM and provide the code that describes the level of service for the encounter. A 99203, B 99212, C 99213, and D 99202. CC, this established patient presents to the office today with complaints of rectal bleeding and itching of 2 weeks duration. Objective, this is a 50-year-old male in apparent good health. His blood pressure is 119 over 78. Rectal examination showed a grade 1 hemorrhoid in the 2 o'clock position, approximately 2 centimeter across. The area around the hemorrhoid was slightly inflamed, and a small amount of blood was noted. Assessment, hemorrhoids. Plan, discussed conservative treatment options with the patient and explains surgical options. He wants to try the more conservative approach of stool softeners and warm sitz bath. I discussed with him the importance of improved bowel habits. He is to return for a recheck in 2 months. Score the MDM and provide the code that describes the level of service for the encounter. And use your PDR chart for this. And coders, your 1 minute begins right now. Thank you.
Yes, that's 1 minute. That was quick, and that is our challenge as well. So let me see. Let me have a look into the chats and let me see how are you doing. Once again, you all are nailing the scenarios. You are become an E&M expert by this time. So let's solve the scenario now together. Let's highlight the keywords as an established patient who presents to the office today with a complaint of rectal bleeding and itching for 2 weeks, and a rectal examination was performed, and in assessment it has found it was diagnosed to be a hemorrhoid, and doctor decided to go for a more conservative approach of stool softeners and warm sit baths. So that's all we are having now. Time to ask the questions. Was there a medically appropriate history and exam performed? How I have read that, yes, there was medically appropriate history and exam performed. And how about the location of this visit this time? Now, this is an office visit, right? And how about the type of the visit? Now, it's an established visit and it's been documented. Was there a total time documented? No, there was no total time documented. So what we are going to do, we are going to use our inventory and PDR table, and we are going to score the MDM. So what we are having, the diagnosis is a hemorrhoid, and the procedure, what the provider did or going to do. Doctor decided for a conservatory treatment with the use of stool softeners, etc. So where does it falls under problem column? I would see it under an acute, uncomplicated illness or injury. Once again, this has been going on for around 2 weeks. So that again falls for a low problem. But I selected one acute, uncomplicated illness or injury. And how about the data? Minimal or no data. I didn't saw any data that has been reviewed in this scenario. So that would be a straightforward level 2 data for me. And the risk, this time I would take it under low risk because doctor has given the stool softeners, which would be over the counter products. So I would go and give a low risk for this scenario. So as we do, we will remove the lowest level and select the next one, and this one is going to be a level 3 low risk MDM, and the correct CPT code is option C 99213. So how are you feeling, coders? Yes, I saw a lot of correct answers. So for others, it's a learning moment. Yes. Okay, great. I can see good responses in the chat. So now it's time for one more. One more. Let's go for one more. The scenario 3. Ms. Jasmith, please and thank you.
Thank you so much again, Mr. Sandeep. Score the MDM and provide the code that describes the level of service for the encounter. Your options are A 99203, B 99213, C 99214, and D 99282. A 7-year-old female established patient was seen by a pediatrician complaining of ear pain for 3 days. A history is then taken. She has an associated fever of 101 °F yesterday. Mom treated her with Tylenol. The fever this AM is 99 °F. She has had some chills and cough and difficulty breathing. No nausea or vomiting. No prior history of otitis. His brother was sick earlier this week. The physician performed an exam of the ENT as well as an exam of the GI, lungs, and heart. Vital signs were taken in the office. The physician diagnosed the patient with otitis media and an upper respiratory infection and prescribed an antibiotic. Score the MDM and provide the code that describes the level of service for the encounter and use the PDR chart for this. Coders, you have a minute to solve this scenario and your time starts right now.
That's 60 seconds. Coders, you all are doing great job over there. So that's scenario 3, and I can see many of you are picking up the pace now and feeling good about the scoring MDM. Now let's highlight keywords for this scenario. The patient is an established patient complaining of ear pain for 3 days. A history is taken. Patient's having a fever of 101 degree Fahrenheit, and she had cough and chills, and physician performed an exam of the ENT, and the physician has diagnosed the patient with an otitis media and upper respiratory infection, and also prescribed an antibiotic. So that's all we have. Let's ask the questions. Was there a medically appropriate history and exam? Yes, there was. Location of the visit, it is an office visit. Type of the visit, is it a new patient or an established patient? It's documented that it's an established patient. There was no total time documented for this visit, so we are going to score the MDM. And in the inventory, we are having diagnoses such as otitis media, fever. There was upper respiratory tract infection, and in procedure, there is an antibiotic prescription which is given. So where do I take it under problem column? For this scenario, I would take it under acute illness with systemic symptoms, because you can see the patient was diagnosed with an upper respiratory infection and otitis media, and the patient was showing the symptoms or systemic symptoms like fever. So that's a systemic symptom, right? So I would take it as acute illness with a systemic symptoms, because both the otitis media and fever can cause a fever, and that's a systemic symptom. So I would take it under a moderate problem level 4. So in data, no data was reviewed for this scenario. So that is going to be minimal or no data. And for the risk, yes, you saw that there is a prescription drug management, and that will straight fall into a moderate level for risk. So as we do, we remove the lowest level and select the next highest, and this one is going to be a moderate risk MDM, and the CPT code is going to be option C 99214. How was that scenario, coders? How are you feeling? Are you doing? Are you feeling good? Yes. Okay, now it's time to move on. We are having one more quick scenario. Yes. Okay, Miss Jasmeet, please.
All right. Thank you so much, Mr. Sandeep. CC, dizziness, subjective. This is a 46-year-old female, established patient, presents today reporting feeling ill yesterday, and she has developed some dizziness. She feels like things stick in her throat and that her throat is sticky. She has a history of hypothyroidism and taking Synthroid 0.125 milligram per day. Her last TSH was last year, and the level appeared to be normal at 0.49. Objective: the patient appears to be in good health and in good spirits. Her blood pressure is 120/81, afebrile, HEENT normal, neck is supple, no palpable masses are noted, no thyromegaly, tenderness, or nodes. TSA is elevated at 9.9. Assessment: hypothyroidism. Plan: increased Synthroid to 0.15 milligram per day. Recheck in 2 months. Score the MDM and provide the code that describes the level of service for the encounter. Coders, you have a minute to solve the scenario, and your time begins right now. Thank you.
It scored us at 60-second, and that was one of the last quick 60-second scenario we have for this final week. So let's solve this one together. Let's highlight the keywords. We're having an established patient. Patient has developed some dizziness. There was a stick in her throat, and patient has a history of hypothyroidism. Her last TSH was normal, and the current TSA is elevated at 9.9, and the patient was diagnosed with hypothyroidism, and there was a plan to increase the synthroid to 0.15 mg. So let's answer the questions. Was there a history performed? Medically appropriate history and exam performed? Yes, there was medically appropriate history and exam performed. How about the location? This one is an office visit. Is this a new or an established patient? Document says it's an established patient. Was there a total time documented for this visit? No. So what we are going to do, we are going to score them again, and in the diagnosis we are having a hypothyroidism with the symptoms. Yes, you can see the patient was having showing up symptoms such as dizziness, there was a stick in the throat, and the procedure we are having a labs a review. The old lab report was reviewed, and there was an order of a new lab as well. The TSA level was also elevated for this visit, and there's an increased dosage of the medicine, right? The doctor increased the synthroid dosage. So that's all the provider did in this visit. And now let's look into the PDR chart, and where do I take it under the problem column? I would take this for a moderate level, but I would take it as a one or more chronic illness with exacerbation, progression, or side effects of the treatment. Because as per the CPT, the chronic illness with exacerbation, progression, or side effect of the treatment is a chronic illness that is acutely worsening, poorly controlled, or progressing with an intent to control the progression and requiring additional supportive care or requiring attention to the treatment for side effects. So you can see the patient had this problem, thyroid problem, hypothyroidism, for around last 1 year. So that's a chronic problem. Of course, hypothyroidism is a chronic problem, and there was an exacerbation. The patient was having symptoms, increased symptoms such as dizziness, and the TSA value was also elevated at this visit. So definitely this is an exacerbation of hypothyroidism. And next, let's look into the data column. Where does this fall? There was a labs review, though there was an order of the new lab as well this visit, so that's 2 point maximum. So I would take it under category 1 in a low data. And how about the risk? There was a prescription drug management, right? They increase the synthroid dosage, so that's a prescription drug management, and I would take that under moderate risk, level 4, the risk column. So throwing out the lowest and taking the next highest, this is going to be a moderate risk MDM, and the correct answer is 99214. So that's the correct answer. And how are you coders feeling about the scoring MDM by using the PDR chart? I hope you all are doing good. Put your responses in the chat. We'll be looking into it. And now it's time to hand over to Mrs. J, and she has got some awesome scenarios for you and aha moments coming up. Ms. J, thank you.
All right. Thank you so much, Mr. Sandeep. And thank you, Miss Jasmeet. And you know what? I was just checking you all out in the chat, and you all are rocking. Don't be hard on yourself if you didn't get it. We only gave you 1 minute. That's it. And you all are nailing it. Even if you didn't get it correct, a lot of you had aha moments. And that is what's most important. You all rock. I even see some of you putting in the answers way before the minute time. So hats off to you. Now it's time to turn our attention to coding guidelines for prolonged services. This is what you said that you wanted more of, that you didn't get it quite. Maybe not all. So we're giving you what you asked for. And thank you to all of you that answered the survey and told us what you wanted. We appreciate you. All right. So when we think of prolonged services, we think of time, right? And when you're coding prolonged services, time is money. Indeed, it is. All right. So, in a moment, we're going to test your knowledge, but I do want to bring to your attention the AMA prolonged service erratum. Yes, there is only one, and this pertains to evaluation and management prolonged services with or without direct patient contact on the date of evaluation and management service. And this is revised time in the total duration of office or other outpatient consultation services. And this pertains to 99245 and 99417 times 2. They've changed the time from 80 minutes to 85 minutes to 99 minutes. So the range is now 85 to 99 minutes, and it only pertains to outpatient consultations. Also, when we're talking about prolonged services, we're talking about time, right? So it's only fitting that you recall and make yourselves aware of the time based activities that are approved as it is outlined in CPT. So don't forget those time based activities. Also, Mr. Sandeep reviewed the age of the patient, diagnosis, signs and symptoms, exams, procedures, total time, medical decision making, data reviewed as all items that you should highlight. This isn't the, how can I say it? We're not saying this is the only thing you need to highlight, but this is the base. We're giving you something to start with, all right? And again, how to select the E&M code, you're going to have to answer the following, answer or do the following. Answer, was a history and or exam carried out? What is the location of the visit? Where in the book in CPT can we find, in the E&M section, can we find that visit? Also, what type of visit is it? Is it new, initial, established, or subsequent? What is the total time of the visit? Or what is the MDM? And if you have to score the MDM just like you've done, you're going to have to inventory, then score. And when you can, use E&M tables to select the codes. And finally, apply all guidelines. All right, so these are pertinent to many of the E&M encounters. And with that said, we have our first prolonged services scenario. And I'm going to invite Miss Jasmeet to the fore, please, and thank you.
Thank you so much, Mrs. J. All right, coders. Diane, a 45-year-old patient with a history of DM2, has been experiencing frequent episodes of hyperglycemia and is struggling to manage her condition with her current medication regime. She arrives at her PCP, Dr. Chandra's office, for treatment. The doctor carries out a medically appropriate history and exam with low MDM, then diagnoses the patient with type 2 diabetes with hyperglycemia. Under his supervision, the nurse Johnson reviews the patient's blood glucose logs, assesses the patient's understanding of diabetes management, and provides education on proper nutrition, physical activity, and blood glucose monitoring techniques. Due to the complexities of the patient's condition and the need of extensive education, Nurse Johnson spends 45 minutes over the typical service time. Code for the encounter is, and coders, you have a minute to solve this scenario, and your time begins right now. Thank you and good luck.
I do want to let them know they have 2 minutes. Moving forward, you have 2 minutes. Thank you, Miss Jasmine. All right, time is up. I see some of you nailing it in the chat. I see some of you attempting it. It's good, really good. This is good stuff. And I see some of you saying, hey, where are the multiple choice answers? Come on. We can do this, and we're going to do it together. All right, we're going to begin with our keywords. A history of diabetes mellitus type 2 has episodes of hyperglycemia. History and exam with low MDM was carried out. And the patient's final diagnosis is type 2 diabetes with hyperglycemia. Nurse Johnson spends 45 minutes over the typical service time. Now, I have a question for you. I have two questions. Do you need to know the physician's level of service to determine Nurse Johnson's prolonged time? Go ahead, type in the chat. I'm going to take a peek. Yes, we do. Because remember, clinical prolonged service time are add-on codes. So if they're add-on codes, we have to add it on to the physician or QHP service, right? So what is the physician's level of service? Go ahead, type it in the chat. Good job. Good job. People are saying low. Some people are saying 99213. You got it. It's 99213. And you know what? You've done 1/3 of the work. Outstanding. I got another question. What is the typical clinical staff time? Well, it says Nurse Johnson spends 45 minutes over the typical service time. So, what is the typical clinical staff time? I don't know. We have to know that in order to calculate the prolonged time because they're telling us it's 45 minutes over it. And the only way we can figure it out is using the typical time chart, right? So, our doctor has low MDM and the nurse spent 45 minutes over the typical time. So we're using this chart, and remember, this chart is for clinical staff, and it is to determine the typical clinical staff time. And we have a guideline right at the top. It says the starting point for 99415, that's prolonged services, is 30 minutes beyond the typical clinical staff time for ongoing assessment of the patient during the office visit. That might resonate for some people, but this resonates for me. All right, so we know the doctor's level of service is low. So we're going to find 99213 on this chart, 99213. And if Nurse Johnson spends 45 minutes over the typical time, then we are going to look at this number here, which is 27, and 45 minutes over it will be 72. So 72 minutes is her prolong or her total time. 72 minutes. And 72 falls between 57 and 101. And if you look up, 99415 can be coded. So we have a typical time of 27 minutes. The time beyond the typical time is 45 minutes. So you add it together, you have 72 minutes. Now, we know we can code 1 unit of 99415, right? And we also know that we can code 99213 with 99415. And that's the answer. How you doing? Is everybody good? Aha! Someone said, aha! Outstanding. All right, so someone said they got it. Good deal. Everyone is self-correcting. I love it. I love it. All right, we're going to switch gears a little bit and we're going to bring Miss Dolly to the fore. Miss Dolly, take it away.
Thank you very much, Mrs. J. All right, coders, you guys are doing a really impressive job so far. I hope you're all ready for scenario number 6. Okay, of the following, which codes best describe the encounter? A, 99214, 99415, B, 99214, 99415, and 99416, C, 99214, 99358, and D, 99214, 99417 times 3. Mr. Bryan visits his PCP, Dr. Patel, complaining of weight loss and moodiness. Dr. Patel performed a comprehensive exam and moderate history with moderate MDM. Dr. Patel tested Mr. Bryan's urine and then ordered blood glucose and HbA1c tests. The tests affirmed a diagnosis of diabetes. Under the supervision of Dr. Patel, Nurse Ross spends time with Mr. Bryan, providing patient education and support to Mr. Bryan, including instruction on daily glucose monitoring, record keeping, medication compliance, dietary habits, and exercise routines. Nurse Ross spends a total of 90 minutes of prolonged service time with the patient. Of the following, which codes best describe the encounter? All right, you have 2 minutes to solve the scenario, and your time will begin now.
All right, time's up, and I love it that I can see you all in the chat today. And I think we got a mix. It's between A and B. Okay, let's go ahead and solve this. Our keywords: weight loss, moodiness, exam and moderate history with a moderate MDM. We have a diagnosis of diabetes, and Nurse Ross spent 90 minutes of prolonged services or prolonged time with the patient. They told us how much prolonged time there was. So before we get to the good stuff, can we eliminate anything on site? Go ahead, type in the chat. Yeah. Someone said, eliminate C and D. You guys are all saying that. That's right, because C is coding 99358, and 99358 is a doctor prolonged services visit code. And also, this code is used only when there's no face-to-face encounter. This scenario, this patient is clearly face-to-face with the doctor, and the doctor is not carrying out prolonged services. How do we know? This doctor had a moderate MDM. In order for this doctor to have prolonged services, two things needs to happen. The MDM has to be high, and his time has to be documented. We'll talk about that later. But this is wrong, and so it's D, because D is also coding for a doctor visit prolonged service. We're coding for the clinical team prolonged services, so we're going to get rid of the distractions, C and D, and let's deal with A and B. So, do we need to know the doctor's level of service to determine the nurse's prolonged time? Go ahead and type in the chat. I see a ton of yeses. You guys are yes, 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 yes. Oh my. Guess what? The answer is no. No. No, because the total prolonged time is documented. The documentation is telling us how much prolonged time we have to code for. And it's simple as this. Look, we have 90 minutes of prolonged time. And if we go to the guideline says code 99415 to report the first hour of prolonged clinical staff time on a given date. Right? We use that chart to determine what the prolonged time is, and we're already given the time. So it's going to be that simple. We're going to go to the code series. 99415 will be coded for the first hour, and 99416 will be for any additional 30 minutes, with the last unit having to be at least 15 minutes or more. All right, so that last unit doesn't have to be 30, it has to be 15 minutes or more. So we've got 90 minutes. 90 minutes is going to equal 99415 and 99416, right? And remember, these are add-on codes, so we have to include the doctor's level of service, and that's going to be B, 99214, 99415, and 99416. All right. I'm not even going to look in the chat because I know some of you are saying, Mrs. J, what are you talking about? All right. Before I speak for you, I am going to peek in the chat. How many of you understand that? And how many of you need more? If you need more, say, I need more. I don't have a problem. All right. Somebody said, I need more. I see you. Okay. I got something for you. Let me tell you why you can just code the prolonged services. All right. So, this typical time chart. Remember, it has a range of time. Remember? So, if you go to level of service 99214, the typical clinical staff time is not 40, it's 40 up to 69 minutes, right? Yeah. And then once you're over 69 and you're reaching 70, then you're in the prolonged time. So we can't determine the exact time within that range because it wasn't provided. However, the prolonged time was provided, right? And we have to trust the documentation. If the professional says, I spent 100 minutes prolonged, that is codable. It's not our job to say, well, what was the typical time and blah, blah, blah. They are telling us what the prolonged time is. This typical time chart is when you don't have the typical time documented. When you don't have the prolonged time documented, I apologize. Yeah, both of those are true. And further, I want to give you an example. Let's say we are using level of service 99214. Let's say the doctor has a 99214 visit. And what if the typical time documented was 40 minutes? And if the prolonged time was 70 minutes for one encounter? And what if you had another encounter and that typical time was 60 minutes and the prolonged time was 70 minutes? The first encounter, the total time would be 110 minutes, and the second encounter, the total time would be 130 minutes. And if you look, this is the point I'm trying to make. 99214 has a span between 40 and 69 minutes to stay in this typical time range. So the nurse has a span of time. So you don't really know what it is unless they document the typical time. And if they don't document the typical time, you use 40, right? Use 40 because 40 you will not overcode. But if you do not know the typical time, you just have to, use 40. And if they give you the prolonged time, then you're good. So look at my two examples. The top one is 110 minutes. The code would be 99415 in addition to 99214. The bottom scenario, theirs is 130 minutes, and their prolonged time would be coded 99214, 99415, 99416 times 2. So the moral of the story is when prolonged time is provided, do not go to the typical time chart because you already know the prolonged time and we can't determine the exact time within the range. We can't. All right. And that prolonged time is already documented. So hopefully that was clear. And if it isn't, I apologize. But now go ahead, type in the chat. Let me know. Someone said, why is it 2? 99416 times 2. Why is it 2? Because the the time 115 minutes is the maximum time here. It stops at 115, and 115 minus 130 is 15. And remember, you can code 15 minutes up to 30 for that last unit. Okay. All right. So that was a great question. Now, we're going to keep going. You guys are getting it. I see all these aha moments, and I'm not going to ask Miss Dolly to come to the fore. I repurposed this scenario just to kind of give you another look. And this is Mr. Brine and Doc. Mr. Brine visits his PCP, Dr. Patel, and Nurse Ross spends a total of 90 minutes of total time. 90 minutes of total time with this patient. Do we need to use the typical time chart for the prolonged services time? Do we need it in this case? Absolutely, we do. It's not prolonged time, it's total time. That keyword, prolonged, right? We don't know what it is, so we need that chart. Also, let's get rid of C and D. They're still wrong. And yes, we do need the chart because the amount of prolonged time was not specified. Now, let's go look at the chart. And I want you to go ahead and code it out. Man, you all are rocking it out. Look how fast you are coming through with that answer. Outstanding. Outstanding, outstanding. Yes, if you go to the level of service 99214, we have a total time of 90 minutes. We just go to our where 90 minutes falls on the chart. It's between 70 and 114 minutes. Code look up 99415, one unit of 99415 with 99214. And that is our answer. And you all rocked it. Okay, so the moral of the story is when coding for clinical staff prolonged services, remember three things. Number one, when total time is documented, use the typical time chart. Number two, when typical time is documented, use the typical time chart and make sure you use the lowest typical time, right? We don't want to overcode. Number three, when only prolonged time is documented, go straight to the code series and code from there. And always remember, typical time has a range of time. And it could be anything, right? So we can't guess. We need to use the chart. All right, so outstanding job. Okay, so hopefully that made sense to you. You had aha moments. I think I saw a ton of them in the chat. Okay, Miss Dolly, please and thank you.
Thank you, Mrs. J. All right, coders, we're on scenario number 8. Of the following, which answer best describes the encounter for the consulting physician? A, 99255, 99417 times 2. B, 99223, 99418 times 3. C, 99236, 99418 times 3. D, 99223, 99417, and 99418 times 3. Dr. Palmer, an endocrinologist, visits his patient, a 60-year-old Mr. Samuels, in the hospital, and then carries out a bedside exam with moderate MDM. Mr. Samuels suffers from multiple chronic conditions, including hypertension and type 2 diabetes, and is hospitalized for complications related to his congestive heart failure. The patient appeared jaundiced, and Dr. Palmer requested that his endocrinology group practice colleague, Dr. Rubinowitz, see Mr. Samuels because he has a subspecialty in pancreatic oncology. Dr. Rubinowitz visited the patient and carried out a medically appropriate exam with high MDM at the bedside. Dr. Rubinowitz ordered labs, endoscopic retrograde cholangiopancreatography, PET scan, and biopsy, and renders a diagnosis of stage 1 pancreatic cancer. On the day of the visit, Dr. Rubinowitz spent a total time of 2 hours working up the patient. He will catch up with his colleague, Dr. Palmer, to discuss his findings. Of the following, which answer best describes the encounter for the consulting physician? And 2 minutes to solve this, coders, and your time will begin now.
All right. I see those answers still coming in. I'm going to give you a few moments. Way to go. I love it. I love it. Don't be afraid. And some people want to see the chat, they want to see all their peers. But at AMCI, I know it's a little different. We don't um, do that. We want you to be free to put whatever you want in that chat, and be free to make a mistake. No one's beyond that, especially me. Okay. So if you just know we don't judge you here. Go ahead and put what you want, what you feel. All right, so you are doing a great job. And someone said they're not confident. You know what? I see you doing an amazing job. I do. All right, so what are the key words? Well, a 60-year-old in the hospital, and Dr. Palmer carries out an exam at bedside with a moderate MDM. Patient has hypertension, type 2 diabetes, congestive heart failure, but Dr. Palmer requested Dr. Rabinowitz, who is in his practice but has a subspecialty in pancreatic oncology. And Dr. Rabinowitz carries out a medically appropriate exam with high MDM, and Dr. Rabinowitz spends 2 hours working up the patient. Is this a consultation? Go ahead, type your answers in the chat. I see yes, no, more no's than yes, but yeah, somebody said, "Hey, I'm thinking no, absolutely it's not," because Dr. Rabinowitz said, "I'm going to catch up with Dr. Palmer. Maybe they're going to have lunch and talk about it." No way, Dr. Rabinowitz. You know you have to document a written report back to your colleague. Okay, he knows better than that. So indeed, this is not a consultation. So we can eliminate on site the consultation code. And if you know your codes, we've been using them a lot over the 4 weeks. You might know that A is an inpatient consultation code. So we're going to get rid of it. It's a distraction. Now, I see some inpatient codes and I see an admit and discharge code. I do see that. But I want to know, is this an initial or subsequent visit? Well, initial visits are defined as, and it's right here, if you can see my cursor, is when the patient hasn't received any professional services from the physician or other qualified healthcare professional or another physician in that of the exact same specialty and subspecialty who belong to the same group practice during the hospital stay. All right, so both doctors are of the same specialty, but they are not of the same subspecialty, and they do belong to the same practice, but the ruling says you have to be of the exact same specialty and subspecialty. And because they are not, Dr. Rubinowitz classifies as an initial visit. So this is an initial visit. So we know that. And if we look at our codes, B and D are both coding that initial visit. That's 99223. And this code 99223 is 75-minute encounter. 75 minutes must be met or exceeded. So now we have to do some math, right? So if Dr. Rabinowitz spent 2 hours working up the patient, let's go ahead and um, break it down into minutes. And those 2 hours will now be 120 minutes. And we're going to take that 120 minutes and subtract it from 75, because 75 will be our level of service code, will be our 99223 code. And anything remaining will be our prolonged services time. So we have 45 minutes remaining and 45 minutes of prolonged services. So we know what it is. That's good. And earlier I said that when you are using prolonged service codes 99417 and 99418, you can only use these when the primary service has been selected using time alone as the basis, and only after the time required to report the highest level of service has been exceeded by 15 minutes. So you must use time. You must have time documented in order to use codes 99417 and 99418. Just thought I would say that. Now, let's go ahead and determine the number of units that we need to code for. Well, if you have 45 minutes of prolonged time, these codes are determined or classified to 15 minutes of increments, 15-minute units. So if there are 15-minute units, all you have to do is divide your prolonged time by 15 minutes, and your answer is 3. So 45 divided by 15 is 3. And 99417 is not codable because that's the outpatient prolonged service code, and D is coding for that. So D is coding also for outpatient and inpatient prolonged services, and this patient is in the hospital, so we are going to get rid of D. And 99418, 15 minutes of total time, and we will code 3 units of 99418. And our answer is B. You all rocked this. How are you? I really want to know how you're doing. Everybody good? I see a okay. I see a good. Okay, I got it. Somebody said, hey, I'm confused, but you know what? You do have the playback. Somebody said I'm learning. Somebody said I'm doing better. Someone said great learning. A lot outstanding. All right. Okay. Well, it's now time for us to move along and we're going to switch gears and we're going to leave prolonged in the past. Now it's time to talk about admit and discharge on the same day. Are you all ready? I found this on the web. She always makes her debut. Bless her heart, Miss Siri. All right, so are you ready to test your knowledge on admit and discharge on the same day? Let's do it. Miss Dolly, please and thank you.
Thank you so much, Mrs. J. All right, scenario number 9. Of the following, which best describes the encounter? A, 99222, 99285 with a modifier 25. B, 99222. C, 99236. And D, 99236, 99285 with a modifier 25. A patient presents to the emergency department with chest pain at 4:00 a.m. The patient was examined, and after a series of diagnostic tests and high MDM rendered, the patient is admitted to observation status for further evaluation and monitoring. During the observation period, the following diagnostic testing was ordered: blood work, EKG, and imaging studies to rule out any serious conditions. After 9 hours, the patient was re-examined with moderate MDM, and the ED physician rendered a diagnosis of atypical chest pain, determining the patient to be sufficiently stable to discharge. The patient was discharged with prescriptions and instructions to return if the problem persists. The doctor's total time spent with the patient is 90 minutes. Of the following, which best describes the encounter? All right, 2 minutes to solve, and your time will begin now.
All right, time's up. How did you do? I saw a lot of you getting it. Outstanding. All right, we're going to begin with our keywords. This patient has chest pain at 4 a.m. in the morning, was examined with high MDM rendered. Then the patient was admitted to observation. After 9 hours, that patient was re-examined with moderate MDM, then discharged. The doctor spent a total time of 90 minutes with the patient. Do I have a question? No, I don't have a question. I think I need to make a statement. I need to go back to the guideline because there was a little confusion. In fact, you all said, hey, revisit this. Tell us, that probably wasn't as clear as it could have been. And I get it. I probably agree with you. All right, so the guideline says right here, codes 99234, 99235, 99236. These codes are used when a patient has been admitted and discharged on the same day, right? Also, these guidelines say that they require 2 or more encounters on the same date, of which one of those encounter is an initial admission encounter, and the other encounter being a discharge encounter, right? So you have to have 2 encounters. Now, when my team and I got together, and I have a great team, and they are medical professionals. Mr. Sandeep is has a master's in pharmacy. Miss Tamika, if you didn't know it, is a physician's assistant, a QHP. And when we get together, we look at these guidelines and we're like, wait a minute, what is the definition of encounter? We can't really, we can't move past encounter. We can't apply this guideline if we don't know what an encounter is. What is the definition? So previously, I was saying an encounter is the proper way that you work up a patient. That is an encounter. And you know what? Probably where you work, you're probably going to be directed to to make sure that the patient was worked up a certain way. So for admission, an admission encounter, they have standards. For discharge encounter, there are standards. But AMA, that's whose guidelines we're following. They didn't specify what an encounter is. So what we've decided to do, since AMA has no definitive definition for encounter, we will have to use the documented language of admission and discharge to mean 2 encounters. Okay? And sometimes in CPT, I see encounter being used synonymously with visit. So hopefully that's fair enough. So moving forward, if your documentation specifies admission and you see an admission in the documentation, then we will trust it. If you see a discharge and a discharge was carried out, we will trust it. So that's how we have to move. Now, let's go back to our scenario. And the question is, was the patient admitted and discharged on the same day? Well, the patient was admitted and the patient was discharged on the same day. So 90 minutes was spent with this patient. So this is going to be straightforward. We're going to go to the front of the E&M manual. We're going to grab the chart that says hospital inpatient or observation care services, including admission and discharge on the same day. And we're going to go down and we're going to select the minutes. But before we select the minutes, make sure that a medically appropriate history and or exam was carried out, and that did happen. The patient was examined, so we're going to presume that the doctor feels that examination was medically appropriate. And then we're going to scroll over to the highest units, which is 85. And that takes us to code 99236. Now, we don't fall into prolonged service time because we do not have 15 minutes or more. There's only 5 minutes remaining. So our answer is 99236. I think that was pretty straightforward. So just remember, if the time was documented, excuse me, not time, if admit and discharge was documented and that occurred, we're going to have to presume that to be correct. All right, so how do you feel? Is that fair enough? All right. Somebody said, hey, what about this? Oh, wait. Somebody said, what about ED? That's not applicable here. It is applicable, but not right here. All right. So hold your horses. Miss Dolly, please and thank you.
Thank you again, Mrs. J. All right, scenario number 10. Of the following answers, which best describes the encounter? A, 99222, 99285 with a modifier 25. B, 99222. C, 99236. D, 99236, 99285 with a modifier 25. A patient who presents to the emergency department with chest pain at 4:00 a.m. The patient was examined, and after a series of diagnostic tests and high MDM rendered, the patient is admitted to observation status for further evaluation and monitoring. During the observation period, the following diagnostic testing was ordered: blood work, EKG, and imaging studies to rule out any serious conditions. After 9 hours, the patient was re-examined with moderate MDM, and the ED physician rendered a diagnosis of atypical chest pain. Immediately after the diagnosis, the patient leaves without proper discharge. Of the following answers, which best describes the encounter? All right, 2 minutes to solve this scenario, and your time will start now.
All right, time is up. How did you do? A lot of you are going to get your question answered. A lot of people had questions from that last time. Oh, why did that happen? Okay. Where am I? I don't see my keywords. All right. So, based upon the, okay, okay, it's doing its own thing. All right. So, we have an admitted, this patient was admitted at 4 a.m. and then 9 a.m. they were discharged. In fact, this person left without proper discharge as soon as they got their diagnosis, immediately after they left. So, is this a same day admit and discharge based upon the guideline? Go ahead, type your answers in the chat. Hmm. No, it isn't. This is not a proper discharge. So, this is one encounter. Although the patient was there, admitted, and left on their own, this is one encounter. I apologize. So my keywords, um, patient spent 9 hours, patient was admitted to observation, a diagnosis of atypical chest pain, and then they discharged. So I have to go to the guidelines. A lot of you were saying, hey, can't you code that ED visit? Well, let's look at the guidelines. All right. So when you have one encounter, the guidelines say C code series 99221 through 99223. So we're going to have to code from that code series because it's only one encounter. The patient did not discharge properly. So we know that. And also, oh, let's go ahead and get rid of C and D. And also, there's a guideline. When a patient's admitted to observation or the hospital from the ED, it's right here. When the patient's admitted to the hospital as an inpatient or observation status in the course of another encounter in another site of service, example, hospital emergency department. The services in the initial site, which is the hospital emergency department, may be reported separately and use modifier 25. So we can code both the admission and the ED visit. Now, some of you were saying with the previous scenario, well, why can't we code that admission? Because that previous encounter is not an admission, just an admission, it's an admission and a discharge. So the guideline says when the patient is admitted, it doesn't say admitted and discharged. If it said that, I would say go ahead and code that ED visit. But like we said, we have to follow the guidance. So you all, a lot of you nailed this. And you know the answer is A, 99222 for your inpatient admission and 99285 with a 25 modifier for your ED visit. All right, coders, I'm going to let that marinade. All right. People are in the chat saying marinated, it's priceless. Yes, yes, yes. All right. That's right. The patient was not discharged. In this case, they did not discharge, so we can apply this guideline. You all are outstanding. Okay, so we got one more scenario, and then we're going to head out of here and give you your CEUs. You all ready? I'm ready. All right, we still have an ED visit. These are the subjects that you all said you wanted, and hopefully you are getting some insight and clarity. Now, are you ready to test your knowledge on this final scenario? All right, Miss Dolly, take it away.
Thank you, Mrs. J. All right, coders, here's your final scenario for the evening. Of the following answers, which best describes the encounter for the ED physician? A, 99221, 92950, 99215 with a modifier 25. B, 92950, 99222, 99291 with a modifier 25. 99285 with a modifier 25. C, 92950, 99291 with a modifier 25. 99285 with a modifier 25, and D 92950, 99291 with modifier 25, 99221, 99285 with modifier 25. Jeff Burlington, a 56-year-old male with a history of hypertension, presented to the ED with complaints of chest pain, shortness of breath, and dizziness. The ED physician, Dr. Shijuade, carried out a comprehensive exam with high MDM. After the encounter, but while still in the ED, the patient became critically ill and went into cardiac arrest. The ED physician performed CPR. Dr. Shijuade spent 60 minutes with the patient before he was admitted into the hospital by the hospitalist. Of the following answers, which best describes the encounter for the ED physician? All right, 2 minutes to solve for this one, and your time will begin now.
All right, our timer was not working, and it is okay. But I want to take a peek and see how you're doing. Let's see what you're up to. Okay, so we're a little bit split here. Yeah, someone said they don't have enough information. All right. So maybe this will be aha moment. Hopefully, if you didn't get it. Okay. So our keywords, we have a 56-year-old presented to the ED with chest pain, shortness of breath, and dizziness. A comprehensive exam with high MDM was carried out. And after the encounter, but while still in the ED, the patient became critically ill and went into cardiac arrest. The ED physician performed CPR, and Dr. Shijuwade spent 60 minutes with the patient before he was admitted into the hospital by the hospitalist. And our task, which best describes the encounter for the ED physician? So we're going to need some guidelines. I'm going to tell you that. All right. And I'm going to the ED guideline because we have critical care in the setting of an ED visit, right? And we talked about this critical care guideline, but we really didn't get into it. So now let's do it. It said for critical care services provided in the ED, go and see critical care code. So generally, if it's carried out in the ED, go just code it as critical care. However, critical care and emergency department services may both be reported on the same day when, after completion of the emergency department service, the condition of the patient changes and critical care services are provided. All right, so it says after the encounter, but while still in the ED, the gentleman could have been waiting for his ride, could have maybe stood up to walk out. We don't know what happened, but we do know this encounter was over. And because this encounter was over, we can report both the ED and the critical care. All right, you all understand that? Now we're going to get rid of A because A is coding for the inpatient admission 99221. You see, the hospitalist admitted the patient, and we are only coding for the ED physician. B is also coding for the inpatient admission 99222. And get rid of that. And so too is D. We're going to get rid of that too. And the answer is C. We're going to code for the CPR 92950. And if you can recall the critical care guidelines, they've pretty much stayed the same. You can code for CPR, and it's in addition to the critical care. And 99291 is 60 minutes of critical care, and 99285 is your ED code. And the answer, 92950, 99291, 25 modifier, 99285 with a 25 modifier. And I guess the moral of that story was to shed light or bring light to the critical care guideline. Right.